Hello, and thank you for joining us for today's webinar, Advancing Health Equity, How to Use Member-Reported Data to Break Down Barriers. I'm Rose Escalante, an Associate Director of Market Development at Phreesia, and I'll be introducing today's presentation. We'll discuss the importance of data collection, measurement, and reporting when it comes to advancing health equity within your member population. But before we get started, I'd like to quickly share some housekeeping notes. Attendees can submit questions at any time using the Q&A widget on the right-hand side of your screen, and I will ask as many questions as time allows. In the resource widget above that, you'll find an overview of Phreesia's payer offerings, Member Connect, and Member Insights. We're also sharing details on how we can help with Medicaid redetermination, as well as results from a survey of nearly 6,000 Medicare beneficiaries during the 2023 open enrollment period, detailing the drivers of a positive or negative experience. And if you have any technical difficulties, please click on the help widget. It has a question mark icon and covers some common issues. And since it's always one of the most frequently asked questions, this session is being recorded and you'll receive a link by the end of the week. Finally, a few brief words about Phreesia. Phreesia is guided by our mission of creating a better, more engaging healthcare experience. Our payer solutions support health plans in attracting and retaining members, understanding their perspectives, closing gaps in care, enrolling members in programs, and identifying self-management abilities. Our digital platform facilitates over 120 million patient visits annually. That's over 1 in 10 visits across the US. And payers leverage the Phreesia network to attract, engage, and better know their members at scale. We're a publicly traded company on the New York Stock Exchange, and our security and privacy efforts are recognized with the industry's top certifications. If at any point during this webinar you have questions about what we're discussing today, or you're interested in learning more about how we help health plans advance health equity, you can request a consultation using the drop-down on the right-hand side of your screen or visit Phreesia.com. Now, I'm honored to introduce our speakers who we're so fortunate to have with us today. Krunal Patel is a director in FTI's Health Solutions practice. Mr. Patel performs data analysis on quality metrics in support of engagements that advise healthcare organizations on operational improvement and short-term and long-term strategies for quality improvement. Cindy Ward is a managing director in FTI's Health Solutions practice, providing strategic consulting and thought leadership on public health programs, enriched by her background as a clinician and a quality improvement professional. She has more than 20 years of experience in government health programs with significant expertise in Medicaid and managed care. And with that, I'm thrilled to hand it over to our presenters. Krunal, Cindy, the floor is yours.
Thank you, Rose. We are here to talk today about advancing health equity and using member-reported data to break down barriers. And we're really excited for this opportunity to share what we have learned in this space and to give some of our best practices to you. Today, we'll be talking about the health equity landscape, what's happening when it comes to CMS, and what's the background to why we're all talking about this today. We're going to briefly go over the CMS final and proposed rules dedicated to the Medicare Advantage program and health equity issues. And we're going to dive deep into some of what we believe are the critical tools that you need to address health disparities, and that's data, getting data that's actionable. We're going to talk about the Health Equity Index at a very high level and what is changing. And we're going to share with you our insights on member and supplemental health equity data that we believe will help you achieve your goals as the STAR scoring is shifting, and how to leverage that data to improve your scores. To kick us off, the health equity landscape is really evolving. CMS is the largest insurer overseeing insurance coverage for over 170 million Americans. This crosses Medicare, Medicare Advantage, Medicaid, the Children's Health Insurance Program, and even health insurance marketplaces. So CMS has a lot of influence in what's happening in the healthcare market. And health equity, or ensuring that all enrollees achieve their optimal health, is a key CMS goal. The good news is CMS is really transparent in what their priorities are. So they developed the CMS framework for health equity, and they've outlined what their priorities are in this space. Those priorities are expanding collection of and reporting and analysis of standardized data, the topic that we're going to be emphasizing for this webinar, assessing the causes of disparities and addressing health inequities, building capacity in the healthcare organizational workforce, a key issue that we're sure most of you are tackling right now. They want to advance language access, health literacy, and culturally tailored services, a key provision in some of the rules that we're not talking about today, but encourage you to dig deeper into. And increasing all forms of accessibility to health services and coverage. Advancing health equity, we see as an expanding goal. We definitely believe that CMS will be advancing this policy over the next few years across all of the lines of business that they oversee. The good news for health plans and for providers is that if you serve enrollees across Medicare and Medicaid and even marketplace programs, there's opportunity to align your health equity strategy across those lines of business. The concepts don't change across the lines of business, and doing the right thing at the right time can help you across all of those lines of business. In fact, we've assisted health plans in several health equity areas that are CMS priorities, including STAR scoring, Medicare Advantage plans who are participating in the value-based insurance design program, and even Medicaid plans who capitation withholds that are tied to quality improvement. And sometimes those improvements include health equity. So things are changing in the Medicare Advantage landscape. The final and proposed rules are probably top of mind for many of the health plans attending this webinar today. So we're going to focus on some of those policy changes. These are very high level. We definitely encourage you to dig into the final and proposed rule a little bit deeper than we're going to talk about today. But wanted to just share with you some of the highlights. In the final rule published in April of 2023, CMS clarified some component care populations. They have really specifically called out special populations. Those include beneficiaries with limited English proficiency or reading skills, beneficiaries that have cultural differences, racial and ethnicity and religious minorities, people with disabilities, those who identify as LGBTQ or other sexual orientation or transgender, and otherwise adversely affected beneficiaries who are living in persistent poverty and inequity. The final rule also requires that provider directories notate non-English speaking providers and locations that are accessible to enrollees with physical disabilities. It requires support for enrollees to learn digital literacy. We believe that this is tied to CMS's goal to expand telehealth as a tool to expand access to care. Plans must also now incorporate one or more QI activities that address health disparities within their quality programs. And then finally, the proposed rule, the Health Equity Index, is changing. Krunal is going to talk about this in a little bit more detail, but the 2027 STAR ratings will focus on improving care for enrollees with social risk factors. And the Health Equity Index reward is going to be and the Health Equity Reward is now going to be based on performance from 2024 and 2025. This means that health plans really need to be looking at your health equity strategy now in 2023, and why looking at your health equity data, we believe, is a critical exercise. So let's take a look at why we believe data is so critical to your success in improving health and health equity outcomes. Data is really one of the most important tools that you have in your toolkit to address disparities. And if you consider the basic model of care to address health disparities, or really to address any health outcome, you'll see that the process generally is to identify and stratify your membership, screen for disparities, which provides most health plans with a wealth of health equity data that you could ingest into your systems and leverage for your future interventions with members. You then engage your members in care, conduct some sort of formal assessment or even informal assessment, develop a plan of care, provide interventions that address or close the loop on those social risk factors or health disparities. You then evaluate the impact and then report on your performance. So you'll see in some of the areas are data critical elements. So developing a great data management strategy and ability to identify health disparities is going to be a critical component to making your health plan best in class. My colleague Krunal Patel will now share with you some more detailed information on the Health Equity Index and how member-reported and other supplemental data are likely integral to your success.
Thank you, Cindy. So, as Cindy mentioned, CMS did finalize the Health Equity Index report. This in itself is actually a transformative approach, which replaces the existing reward factor. This is a significant change because this shift takes us from solely promoting high performance and low variability to actively encouraging the reduction of disparities in healthcare. Now, as Cindy mentioned earlier, this will take effect in the 2027 star rating, which is going to be based on the performance in 2024 and 2025. The reward itself is designed to promote equitable healthcare, particularly for members with social risk factors that might act as barriers to quality care. CMS expects these clinical outcomes for members with social risk factors to be on par or even better than outcomes for other members. The Health Equity Index is designed to address disparities in healthcare among individuals that have these risk factors, which includes various conditions or even circumstances that put individuals at higher risk for health issues, which could potentially limit their access to healthcare. CMS has initially defined this group as members receiving a low-income subsidy, those duly eligible for Medicare and Medicaid, and or even members with disabilities. Now, this definition is based on the findings that were reported to Congress previously that revealed that duly enrolled or low-income subsidy beneficiaries, those living in low-income neighborhoods, and beneficiaries with disabilities are often the ones that experience the worst outcomes compared to other beneficiaries on many of the quality metrics that are included in the star rating program. While CMS has not announced specific measures just yet, which is going to be part of the HEI calculation, it is safe to assume and understand that it is expected to the HEI to include member outcomes and experience measures such as HEDIS, CAP, medication adherence, and the like. So now the big question is, what should a Medicare Advantage plan do next? Well, firstly, it is crucial to know your members. Therefore, the first step is in actual fact to identify the members with these types of social risk factors. Now, we understand member-reported data is a gold mine. It really is a gold standard, and it is crucial to acknowledge that this is a very important piece of the puzzle. Now, it is very important to also realize some of the limiting factors of member-reported data. One of the limitations that is very to the top is majority of times this data is incomplete. Not all the members report or even ask about their race and ethnicity identification, which leads to gaps in information collected. Another challenge that comes from this is inaccuracy in the data that is reported from simply imputing the data incorrectly, which can come from either misunderstanding what's actually on a form or just mistranslation or even just data collection errors. This further adds to the challenge where the lack of standardized race and ethnicity categories adds to the limitation factor. Without consistent and comprehensive categories, it becomes challenging to analyze and compare data across different data subpopulations. Now, identifying health disparities becomes even more complex for members that identify themselves either as biracial or multiracial. This is true for individuals because they may face challenges when selecting a single racial or ethnic category, which makes it difficult to capture the specific health need for those types of member or member groups. Additionally, some members may even refuse to provide race and ethnicity data, and this is possibly for privacy concerns or even personal preferences. This tends to lead to create additional gaps in data, which hinders the effort in addressing health disparities effectively. So all these things that are adding up, we are talking about the challenges in this member-reported data. How do you overcome this? Well, one really good tool, a very invaluable tool, is health risk assessment or even health assessment tools. They really play a vital role because through this types of assessment tools, a health plan can capture race and ethnicity information, which can be then incorporated into various programs, including member profiles, clinical platforms, stratification algorithms, and most importantly, reporting platforms. Given the challenges and limitations of member-reported data, health plans generally need to supplement this with other sources. And these additional sources can help in identifying and addressing health disparities within the membership or of a population base. Now, while supplemental data sources are not considered the gold standard, they serve as a valuable alternative for capturing important information. For example, health plans often leverage census data to obtain demographic information about populations. This can include race, ethnicity, income levels, and even education levels. Provider-reported ICD-10 Z codes are also another source that health plans tend to utilize. These codes denote factors influencing health status or social determinants of health, such as inadequate housing, illiteracy, or inadequate food. Health plans often incentivize providers to report these codes as they provide valuable insights into the social and environmental factors affecting patient health. Additionally, health plans also use different types of sources such as health information exchanges or HIEs. HIEs facilitate the secure exchange of health information between different healthcare organizations. They tend to provide a demographic and utilization data on patients, which allows health plans to access more comprehensive information about patients' age, gender, ethnicity, and other key demographic factors that can be used in better stratifying the member-reported information. Another primary source used by health plans is electronic health records, or EHR. This has become a more common thing within the last 2 years as more and more health plans are getting connected in with the EHR systems. They actually contain comprehensive medical records. This is truly invaluable data because not only do you have patient health information, diagnoses, treatments, tests, results, but additionally, a wealth of additional data that is really something that health plans can use to supplement the member-reported information, which can therefore give a more comprehensive understanding of their patient or member demographic makeup. Other sources listed here to the right are also additional ways that health plans could use to capture population or other member demographic factors to further stratify their membership. Cindy?
Thank you, Krunal. So what we know is that STARS is evolving from a place where health plans needed to be really good at identifying and closing gaps in care. That will continue to be a core competency, but now health plans and providers as partners will also need to ensure that beneficiaries with health disparities are able to achieve their best outcomes. And to do this, we believe health plans need reliable member-reported and supplemental data to be best in class at achieving health equity. With good data, plans are going to be able to identify disparities in outcomes and target interventions for equitable care. You'll be able to track and trend performance and evaluate the effectiveness of your interventions. You'll also be able to direct resources to the interventions and services that best reduce those disparities, and overall enhance the quality of care for all of your beneficiaries, we believe, across lines of business. At FTI, we believe that the most successful health plans will be those that collect and leverage member-reported health equity data and really select the best supplemental forms of data for those data sets. Those plans will be the most successful as STARS scoring evolves to include more emphasis on equitable outcomes for all beneficiaries. We thank you for your time today and welcome questions.
Thank you so much for such an insightful presentation. I'm really excited to share some of the questions that we've been getting throughout this presentation. So audience, please keep sending them in and we'll get to as many as we have time for. So Cindy, maybe I can start with you for this first one. We've talked about how member data quality can be a challenge, and this question addresses just that. Why is member demographic data often inaccurate, and how can we improve the quality of it?
I think Krunal touched on some of the elements. There's inconsistent ways that this information is collected. One of the reasons that the health risk assessment can be so valuable is the health plan sort of owns that data set. They're collecting the information, they're ingesting the information, and they're getting it at the point of contact with the member. But you'll have to supplement that, obviously, and you want providers who are collecting this information, or you want other self-reported data. But even that self-reported data can have its challenges. Some members don't want to report. They have challenges selecting the ethnicity that seems like a fit for them. Sometimes the categories don't feel right, and they can be very limiting. If I'm Puerto Rican, for example, I can be an African-American Puerto Rican. There aren't typically selections for me, so I don't see myself sometimes in a list, or get frustrated and don't select. There's also lack of updating data. So how frequently are we revisiting this? People think that sometimes that ethnicity and race are static. For a lot of folks, that's not true. Their identity may evolve over time. So recollecting that data can also be important. And then there's just the variety of ways that you get this information. If you're getting data on race and ethnicity from multiple data sets, consolidating that information into one file or one data set for you to be using that information, those are big challenges for health plans. And that's a lot of IT background support that you may not have the resources right now to dedicate to. So thinking through where those gaps are we believe in 2023, 2024, doing that analysis of what you have and the data sets that you have access to and how you can best consolidate that information, we think is a really important exercise over the next 12 months.
Thank you. That really touched on a lot of different challenges that, not only the health plans are facing, but patients might be facing too. So this next question actually feeds nicely into some of the content that you spoke about, Krunal, and maybe Cindy, you can jump in too. So we talked just now a little bit about the pain points and the challenges that health plans are facing, but how do you think that the healthcare system should be thinking about communicating this to patients and encouraging them to update and provide that information?
That's an excellent question. One of the ways that health plans can actively reach out to members, it really comes to member education as well, right? Like to actively work with members to ask them at either enrollment or post-enrollment, right? When we have the welcome packet, following up with these members. One great tool that we discussed is the HRA, is including questions in the HRA to ask what their race is, what their ethnicity is. Now, you could further this by identifying, you may have some information through the CMS enrollment files. That's a possibility, but if you don't have that, you can now ask those questions to specific targeted and membership that you don't have that data on today. So you can change that perspective differently by looking at different subgroups and analyzing that data set.
I would just add that from my clinical perspective, putting my clinical hat on, trust is really important when it comes to almost anything that you do with beneficiaries. And collecting this information from and at a place that is trusted for me, my provider, my community health worker, my promotora, I think those are the opportunities that you have to get more accurate information and to get members who are more readily providing that information. So if I'm a health plan today, I should be looking at where those touch points are for my beneficiaries and the best places to try to collect that information and who my trusted partners are going to be moving forward.
And just to piggyback on that, how do you think that providers, as you mentioned, clinicians should be encouraging patients to provide this information? Because as you mentioned, one of the many challenges is that patients just refuse to provide it. They don't feel comfortable and they don't trust their health plan or their provider in some cases. So how can we overcome that?
Yeah, that's a really great and challenging question, Rose. And I think it's something that a lot of health plans have thought about. If I'm coming in to see a provider, especially if I'm from a vulnerable population, that trusted relationship really is the place where I can leverage that it's safe to provide that information. We have marginalized communities that they are fearful for, if you're an undocumented immigrant or you're the mother of an undocumented immigrant, like you have this fear factor that sometimes permeates these questions around race and ethnicity that I think we have to recognize. I think we also need, as health plans, to look at our providers as partners and educate them on why are we collecting this information. Providers may believe that the census information is sufficient, and why aren't health plans leveraging that? Why do you want me collecting this information? And then providers rightly share, you're asking me to do one more thing. What's the incentive for me to also do that and be a participant in this? So it's really looking at not only who my partners are, but how am I going to incentivize and make it easy for them to be a participant and a partner? And then to educate them on the purpose so that they can then turn around and give good information to members when we're asking the question about race and ethnicity and other disparities of what we're using this information for, and that it's not something that's nefarious. It's definitely something to help you personally and potentially you as a community.
Yeah, thank you. That's a really great perspective and helpful insight. We've got another question following on this thread of payers and providers. So this question says, how does the perspective of payers on health equity differ from that of providers, and how can they work together to advance health equity? Do you want to take that one again, Cindy?
Sure, and I'm going to let Krunal jump in because I know he has some really good thoughts here. I go back to providers as partners. The health plans can't do anything in a silo, right? It's the providers who are providing the services. They're the ones that typically have to FaceTime with the member. So I think the difference that health plans have to look at is, how do I support my providers? And I can support my providers with really good health equity information. If I'm stratifying the membership, if I'm collecting health risk assessment data, and I know this particular provider has a large group of beneficiaries with health disparities, I should not only be sharing that information with the provider, but partnering with them on the interventions that we collectively need to do to address those disparities. It's really asking providers a lot to know every food bank in a community. They may know one or two, but putting all of the onus on the provider to then ameliorate those identified disparities, that's not a partnership in my mind. And I think the really good health plans are recognizing that my role as a health plan is to make my provider's life as easy as possible, to be as good of a partner to provide the information and tools that they need. And if they're willing to tackle health disparities at the local level, give them all of the tools that they need to do that and to be successful.
And one thing to add to that, Cindy, it really is what highlights the most important piece. It is a partnership. It's not to say, hey, providers have, one aspect of it and health plans have to do another piece. The only way we're going to truly address these health disparities is a partnership between providers, health plans, healthcare organizations, community organizations. It really does take a village to kind of come together to help find some of these answers. From the health plan's perspective, other additional things that health plans can do that is not specifically provider focused is member education, working with community groups and really identifying what additional member education can be leveraged such that it's either in a language or a dialect that is specifically for that population, so they can truly understand why it is important for them to kind of get some of the benefits that they are already the health plan offers them, that they may not know of those different types of benefits. So really educating members is going to be another key aspect.
Definitely. Yeah, I think that, you talked about the partnership between providers and payers, and I think that's so critical because I'm sure just enhances the trust that patients will hopefully have in their provider and payer partners. So we've got another question coming in, and Krunal, given that you talked a lot about the data and data sources, maybe you can grab this one. So what types of data are most important for health plans to collect and analyze when they're creating health equity plans?
So that's a very big question there, right? So one of the most important pieces is HEDIS itself has started collecting these various race ethnicity data already in some of their measures today. So that has started starting with 2022 measurement period, and they're expanding. NCQA has now said that they will be expanding that to additional measures in the future as well. So it's already started, in terms of not just like race and ethnicity, but you also need to kind of start thinking about collecting education level, right? If there is like specific areas that may not have, maybe there's a stronger presence of illiterate type of a population that does need that additional help, right? So you really need to understand that subgroup. Another aspect of it is also food insecurity, right? That's a very big thing that I see. Cindy probably has seen this in the Medicaid space often, where these data points, when you actually have that, you're able to now specifically target those member interventions and be able to now target your benefits even that can address some of these potential challenges that your community or your members are actually facing today.
Great. And I know that, you could probably go on about the types of data, and it's a big question, but it's helpful to at least get started with where health plans should be focusing. So I think we've got time for just about 2 more questions. So this one is, maybe Cindy, you can grab this one. How can Medicare Advantage plans who work under a capitated or fixed fee best articulate ROI when it comes to health equity initiatives?
Great question. And I think one that health plans are struggling with. It's sometimes easy to look at addressing health disparities as sort of a check the box exercise. There are certain things that I need to do to get over the hill, but I'm not going to invest a ton of resources here because I don't know that there's an ROI. We truly believe, and I think there's enough studies out there that show, you've probably heard the saying, 20% of the population spends 50% of the costs or some variation therein. And if you look under the hood, we're really talking about people who have disparate outcomes for the same type of care. So I think it's important to look at what can you do to identify those populations that are driving those costs And if you identify the right interventions to apply there, and I believe that they're a partnership of clinical interventions and addressing social risk factors or those social determinants of health, you can in fact bend the cost curve. And it's a big competitive edge to be the health plan that does this really well. Not just in the Medicare Advantage space where you get rewarded, and as stars evolves, you'll get more rewards by being able to address health disparities. But in the Medicaid space, if you're really good at addressing health disparities, you're going to be more poised to be a winner in the markets where those markets are competitive. In your commercial space, you're bending the cost curve on something that maybe your competitors aren't even paying attention to. So I think it does take, harkening back to the data, you have to identify the populations first in order to be able to do that compare and contrast and evaluate if you're bending the cost curve, and then evaluate which interventions are the ones that are actually the most effective. So I think it's a worthwhile exercise to think about an ROI when it comes to health disparities that go beyond just the rewards of being performing very well under stars, but taking it further and looking to see, is there a financial benefit to us as a health plan for being really good at these things? And I think if you undertake that exercise, I think you'll find that there is more financial benefit than meets the eye when you first start the exercise.
And Cindy, one thing to add to that, when you think of ROI, another often overlooked piece of the ROI is when you are offering this type of healthcare, right? That's equitable healthcare. Your members actually are appreciating that, which means that they're not going anywhere else, right? So you have your members are willing to stay with you, right? Which further reduces costs in finding new members. But when we kind of look at the broader scheme here, right, as health plans start doing these things, they're in essence helping the broader community help become healthier over time. That itself is a non-tangible ROI, but truly something that CMS is looking at today, and really looking forward to seeing what that's going to be in the future as well, with this focus on the equity healthcare.
Thank you both. That was a great segue to our final question. So what we've got is, if you're advising a plan that wanted to take its first step in enhancing its health equity efforts, what would you suggest as their first and foremost priorities? I know we've talked about all the things that we've got to do.
It's a loaded question, but let me give it a try here. If we were to advise a plan to, aim their how to kind of increase their health equity efforts, I think the first thing is you got to have a priority by establishing a robust data collection piece and analysis. You need to have data in order to know what's really the starting point. Understanding the current state of health disparities among the members that you have is truly essential. And this can be achieved by carefully examining the data related to health outcomes specifically, service usage, even potential barriers that they face in accessing that type of healthcare. Now, after you have this type of a detailed understanding from the data perspective, the plan, I think, then can proceed in creating a culture of health equity within the organization. You got to get everybody on board at the end of the day, right? I think this is kind of saying, hey, let's have everybody within the organization kind of push on this health equity piece. This could involve training, educating employees across the entire spectrum, from leadership to frontline staff, right? They really need to understand what health equity entails and its actual significance. When you have those two things, the next piece I feel is providers, because again, it goes to the partnership, right? The culture of health equity needs to then extend to the providers. And as Cindy mentioned, there really is, when you build that incentive structure in for the providers, then it creates a more valuable partnership. When you have all three of those things, right? But when you have the understanding of your members through the data piece, you have an internal culture that promotes health equity, a network of providers that are aligned with the goals of health equity, then the next big piece I feel is member education, right? They need to be educated on the available resources that they have, the services that they can get, the support that is designed for them to address disparities. And honestly, the whole point is to promote health equity. And when we kind of step back, this step-by-step type of an approach, starting with data, moving through an organizational shift in health equity culture, with kind of the ending point with when you land with the member communication piece, it really is a good foundation for a plan looking to enhance health equity efforts, I believe.
Thank you. Yeah. Anything to add there, Cindy?
The only thing that I would add is I would view health equity as a lens through which you look at your entire operations. I know as health plans and as providers, we don't want members having a different outcome with the same service. We want beneficiaries to have a good experience with our providers, with our services. Dig in, see where you're not meeting that mark and try to figure out the why. It's not always race and ethnicity that's driving some of those disparate outcomes. What is particularly driving it with your populations? It will be unique, but put the health equity lens on to just make sure that you're evaluating all of your beneficiaries to make sure they're getting their best outcomes. And then really think about culture. Culture from a member perspective is very different from race and ethnicity. How do they interact with the health system? Is your network broad enough to have services and providers that look like and talk like me? Look at your beneficiary profile and try to emulate the network that you need in order to serve that beneficiary population beyond race and ethnicity, but just to build a network of providers that are attractive to me.
Yeah, that's definitely a huge undertaking, but I think a super impactful goal. So thank you so much for giving us those insightful and really positive perspectives on a big problem that health plans are facing today. That's all the time we have for today. Unfortunately, I want to sincerely thank Cindy and Krunal for an engaging and informative presentation. Don't forget, if you have any questions for us here at Phreesia, or you want to see how our platform works, you can request a consultation using the form on the right-hand side of your screen. Thank you again for joining us.